দুটো পার্টে হবে। The first class today will be on the cardiac glycosides and the next class will be on the treatment modalities for the heart failure. ওকে, তোমাদের হার্ট ফেলিওর উপর দুটো ক্লাস হবে। একটা ক্লাস, প্রথম ক্লাসটা আজকে নেব আমরা, এটা কার্ডিয়াক গ্লাইকোসাইডস উপরে রয়েছে, and the second class will be on the treatment for the heart failure. So now cardiac glycosides. The term glycosides basically is a chemical structure containing a non-sugar moiety combined with a sugar moiety by a glycoside linkage. It can be in oxygen or nitrogen or carbon or oxygen. Basically, cardiac glycoside is consists of an aglycon genin to which is attached one or more sugar moiety. This is the structure of digoxin. Digoxin is one of the cardiac glycoside and is the only cardiac glycoside that is presently in clinical use. Cardiac glycoside মধ্যে only digoxin এই মুহূর্তে ইউজ করা হয়, not others. Is the structure of digoxin. You see, this is the non-sugar moiety containing a steroid structure with a unsaturated lactone. This is bound to the three sugar molecules by a glycoside linkage. You see, this O is the glycosidic linkage. Now, what is the advantage? What is the function of cardiac glycoside? They basically increases the force of contraction of the heart, and the force of digoxin or the cardiac glycosides are less sensitive to the normal heart. So they have got positive inotropic property. They are found in several plants. The source of cardiac glycosides are several plants and also toad skin. In the toad skin, it is called bufotoxin. Now, cardiac glycosides known as digoxin, digitoxin, ouabain and others. And as said earlier, digoxin is the only cardiac glycoside that is currently in medical use. The source of digoxin is the digitalis lanata, while the source of digitoxin is digitalis purpurea, and the source of ouabain is Strophanthus gratus. Now, the history with the digoxin or the cardiac glycoside. Now, William Withering was a Birmingham scientist who basically tried an extract of foxglove containing digitalis to a patient of dropsy. Dropsy means having edema, and found remarkable effect, and found it to be remarkably effective in some cases of dropsy. Now, he thought the beneficial effect of the action of digitalis on the patient of dropsy is due to action on the kidney. It was Pusney and Mackenzie in the early 20th century. They basically established that the action is on the heart, and they established the use of digitalis in a patient of congestive heart failure. Now, coming to pharmacological action of digitalis. They are on the heart, particularly on the heart, definitely, on the blood vessels, on the kidney, and on the central nervous system. Now, coming to the pharmacological actions on the heart. Now, what are the actions on the heart? Number one, it increases the force of contraction of the heart. So, direct effect on myocardial contractility. And the second effect is on the electrophysiological properties. We will come one by one. Vagomimetic action. It increases the vagal tone. Reflex effect due to alteration in hemodynamics. Now, in a patient of heart failure, we know there is increase in sympathetic overactivity. Now, what does digoxin is doing or digitalis is doing? It is increasing the heart contractility. So, the reflex sympathetic overactivity is abolished, and thus they are reflex effect due to alteration in hemodynamics. They have got also direct central nervous system effect, altering sympathetic activity. Now, coming to the force of contraction. Digitalis in the normal heart does not increase significantly the force of contraction, but in the failing heart, it significantly increases the force of contraction of heart, and basically without disproportionate increase in oxygen consumption. We know that the adrenergic drugs, they also increase the contractility of the heart, but they increase the contractility of the heart with disproportionate increase in oxygen consumption, and hence the myocardial efficiency is decreased. यदि oxygen consumption टा बाढ़बे तो cardiac workload टा बाढ़बे. Now what does digoxin is doing? It is increasing the force of contraction but without increasing the oxygen consumption. So myocardial efficiency is maintained or increased rather. Now what happens? More complete emptying of the failing and dilated ventricle leading to increase in cardiac output and end diastolic volume is reduced. Now this is a schematic diagram showing the function of the heart, normal heart and the failing heart, or rather the contractility of the normal heart and the failing heart to increase impedance to the outflow. Now what we are seeing, as the arterial impedance is increasing, the stroke volume is maintained to a larger extent in the normal heart. How it is doing? By increasing the tension in the heart. Intraventricular tension in the heart is increased, leading to maintenance of the stroke volume. Now, at significantly higher level than in the normal heart, the stroke volume is decreasing. But when coming to the heart failure patient, even in slight increase in the arterial impedance, the stroke volume decreases. Now, when this patient of heart failure is given digitalis, that is a digitalized heart, there we see that the increase in arterial impedance, to some extent, stroke volume is maintained. Now coming to the heart rate, effect of digoxin on the heart rate. In a normal heart, basically there is insignificant effect on the heart rate, but in the failing heart, the heart rate decreases. It is more marked in congestive heart failure patient. Why? Because number one, direct vagal effect. Number two, as the heart failure patient is given digoxin, the myocardial contractility is increased, leading to abolition of the reflex sympathetic overactivity, and thus the heart rate decreases. Improved circulation due to positive inotropy restores diminished vagal tone and abolishes sympathetic overactivity. Also by vagal effect, by increasing the vagal tone and extravagal effect, the SA node and AV node depression occurs due to use of digitalis, and thus it causes increase in basically decrease in the heart rate. Now coming to electrophysiological property, this is the action potential of the cardiac myofibers. Now the effect of digitalis on different fibers of the heart are different. For example, some phase of the action potential is more affected in the AC node or AV node rather than Purkinje fibers. Hello. Now this is the action potential of the normal heart, and the red one is due to the effect of the digitalis. What we are seeing, the resting membrane potential, this is the resting membrane potential, progressively decreases to the lesser negative values, and hence the excitability increases at the therapeutic dose. Now the rate of phase 0 depolarization is decreased. So the rate of phase 0 depolarization is reduced, so there is slowed conduction. This is most marked in the AV node and the bundle of His. Now the slope of phase 4 depolarization is increased, and hence it is more marked in the Purkinje fibers, and there is increase in ectopic automaticity because of this action. Again, the resting membrane potential due to the effect of digitalis, so oscillatory movement, and when the amplitude of the potential increases to a certain value, there is delayed after depolarization. SA node and AV node automaticity is reduced, leading to basically decrease in the heart rate. Action potential duration is reduced. The effect is most marked in the phase 2. Effective refractory period. Now, effective refractory period in different chamber of the heart is different. In the atria, effective refractory period is decreased. Why? Because of vagal action and increased by basically they are dual action. Digitalis, they decrease the atrial effective refractory period by vagal action, and they increase the effective refractory period by the direct action. How? By the vagal action. But the ERP is increased in the atria by the digitalis by direct action, but the vagal action predominates. As a result, effective refractory period in the atria is decreased. The effective refractory period in the AV node and the bundle of His are increased because of the direct action, vagal action, and the anti-adrenergic action. In the ventricle, they are decreased by the direct action. Conduction. The atrioventricular conduction is decreased, is slowed by the therapeutic dose. But at toxic doses, intraventricular conduction in the Purkinje fibers are also decreased. ECG. Digitalis, they show the ECG electrocardiographic changes even at therapeutic dose, but at toxic dose it can lead to various type of arrhythmias. The effect of digitalis on the ECG, they cause either decrease in the amplitude of the T wave or inversion of T wave. They increase the PR interval because of slowed AV conduction. Again, the QT interval is shortened. Why? Digitalis is increasing the force of contraction of the heart. So systole is shortened and diastole is prolonged. And because of shortening of the systole in the ECG, the systole is shown by the QT interval. So as the systole is shortened, QT interval is shortened here. And again, they cause depression of the ST segment because of interaction with the ventricular repolarization. Mechanism of action of digitalis. Mechanism of action of digitalis. Now, how does digitalis is causing increase in force of contraction of heart? They act on the sodium potassium ATPase channel. Now, they bind to the sodium potassium ATPase channel present in the myocardial fibers at the extracellular phase. Which? Now, this is a schematic diagram showing the mechanism of action of digitalis. This is a myocardial fiber. Now, they are containing at the membrane level sodium potassium ATPase pump. Now, digoxin is binding to the extracellular phase of the sodium potassium ATPase and inhibiting this enzyme. What does this enzyme do? They cause extrusion of the sodium ion and intrusion of the potassium ion. তিনটে সোডিয়ামটা বার করে দিয়ে দুটো পটাশিয়াম ঢোকানো হয় by sodium potassium ATPase enzyme. Now, when digoxin is inhibiting this enzyme, intracellular sodium is increasing. এখানে কোনো অসুবিধা আছে? So because of the inhibition of the sodium potassium ATPase enzyme in the myofiber, intracellular sodium is increasing. Now, because of increase in intracellular sodium channel, it basically inhibits sodium calcium exchanger. Sodium calcium exchanger কি করে? সোডিয়ামটাকে ভেতরে ঢোকায়, ক্যালসিয়ামকে বার করে. নাও যেহেতু সোডিয়ামটা অনেকটা বেড়ে গেছে ইন্ট্রা সাইটোসোলে, তাহলে gradient of the sodium across the membrane is disrupted, and so now calcium is not being extruded out from the sodium calcium exchanger. As a result, due to increase in intracellular sodium ion, calcium concentration increases in the cytosol, and it has been seen that even a small increase in the intracellular sodium ion lead to large increase in the calcium concentration. Now this excess calcium is taken up by the sarcoplasmic reticulum, and calcium loading in the sarcoplasmic reticulum increases. And we all know that the calcium plays a major role in the myocardial contractility by action of troponin C on the myocardial fiber. So the myocardial contractility is increasing because of increased calcium concentration in the cytosol of the myocardial fiber. Increases the force of contraction of the heart by direct action independent of the innervation. Extracellular phase of the membrane associated sodium potassium of sodium intracellularly, leading to diminished calcium extrusion. So the intracellular calcium accumulation occurs. Excess calcium remaining in cytosol is taken up in sarcoplasmic reticulum, which progressively gets loaded with more calcium so that subsequent calcium transients are augmented. Now binding of glycoside to the sodium potassium enzyme, ATPase enzyme, is slow. So the action of digitalis on the myocardial contractility is slow. It takes hours to develop even after intravenous administration. Inhibition of sodium potassium toxic action of digitalis. Mind it, digitalis, they have got very narrow therapeutic index and got high toxicity. So how the toxicity is occurring? Because of inhibition of the sodium potassium ATPase enzyme, the potassium depletion occurs intracellularly. Sodium potassium ATPase enzyme কাজ করতে পারছে না, তার জন্য সোডিয়ামটা বাইরে দিতে পারছে না, তো পটাশিয়াম ভিতরে ঢুকছে না, intracellular potassium depletion occurs, and hence digitalis toxicity can be partially reversed by infusing potassium, because potassium decreases binding of glycoside to sodium potassium ATPase. Number 2, because of excessive calcium loading of sarcoplasmic reticulum, they result in spontaneous cycle of calcium release and calcium uptake, producing oscillatory delayed after depolarization. আমরা পড়েছিলাম না আরএমপিটা resting membrane potential, they are showing oscillatory movement, and that can result in delayed hyperpolarization in the electrophysiological effect. So because of excessive calcium, they produce oscillatory delayed after depolarization and after contraction. Since both therapeutic and toxic effects of digoxin are due to myocardial calcium loading, these are inseparable, and therapeutic index of digoxin is low. Increase in cytosolic sodium concentration in the myocardial fiber, so that calcium accumulation occurs in cytosol because of increased intracellular sodium ion concentration, and this calcium is taken up by the sarcoplasmic reticulum. As a result, due to excessive calcium loading in the myocardial fiber, myocardial contractility is increasing. Now these were all on the action of digoxin on the basically heart. Now action of digoxin on the blood vessels. It has got weak direct vasoconstrictor effect. As a result, peripheral resistance is increasing. However, in congestive heart failure patient, because of increase in contraction, there is abolition of reflex sympathetic overactivity, and as a result, action of digoxin in the heart failure patient is decrease in peripheral resistance. They have got no prominent effect on the blood pressure. Systolic blood pressure may increase, diastolic blood pressure may fall, causing increase in the pulse pressure. Okay, and hypertension is not a contraindication for digoxin. Therapeutic doses of digoxin, they have got insignificant effect on the coronary circulation, so they can be prescribed in the coronary insufficiency patients. Action of digoxin on the kidney. It has got no direct effect on the kidney, but due to increase in the myocardial contractility, the peripheral perfusion is increasing, so the renal blood flow is increasing, and that is causing diuresis. The retained salt and water is gradually excreted. No diuresis occurs in the normal individual. And myocardial contractility বাড়াচ্ছে না, তাই জন্য diuresis হচ্ছে না, or in patient with edema due to other causes. So particularly it is effective in edema of congestive heart failure patient, not in other cases. Action of digoxin on the central nervous system, little effect at therapeutic dose. Higher doses causes chemoreceptor trigger zone activation, causing nausea and vomiting. Still higher dose produce hypopnea, central sympathetic stimulation, mental confusion, visual disturbance, disorientation and others. Pharmacokinetics. Very important, bioavailability of digoxin of different manufacturers may be different. So a patient on one brand of digoxin should not be converted to some other brand. Presence of the food in the stomach may delay absorption. Volume of distribution is very high, 6 to 8 liter per kg. So in patient of digoxin toxicity, hemodialysis has got no role, because the volume of distribution is high, 6 to 8 liter per kg. They are concentrated in the heart, skeletal muscle, liver and kidney. Primarily excreted unchanged by the kidney, mainly by the glomerular filtration, and rate of excretion is altered parallel to creatinine clearance. So half-life is prolonged in the elderly subject and in patient with renal failure, and in those cases the dosage of digoxin has to be reduced. Adverse effects. We all know that digoxin has got very narrow therapeutic index, and hence the margin of safety is low. Therapeutic index is 1.5 to 3. The toxicity of the digitalis can be divided into two groups. One is extracardiac toxicity and the other one is cardiac toxicity. Extracardiac, anorexia, nausea, vomiting, abdominal pain are first to develop. Why? Because of chemoreceptor trigger zone activation, mesenteric vasoconstriction, and because of gastric irritation. So anorexia, nausea, vomiting and abdominal pain are reported first. Diarrhea can also occur. Fatigue, malaise, headache, mental confusion, restlessness, hypopnea, disorientation, psychosis, visual disturbance are, and the skin rashes and gynecomastia are rare. Now coming to cardiac toxicity. Any type of arrhythmia is possible in digitalis toxicity. Arrhythmia মানে কি বলতে পারবে? Anyone? Arrhythmia মানে কি আছে? We all know that the impulse for the cardiac contractility arises from AC node. From there the impulse travels to the AV node via the atria, and then from the AV node via the bundle of his Purkinje fibers the ventricular contractility occurs. Right? তাই তো এটাকে বলা হয় sinus rhythm. because the rhythm is arising from the SA node. Now, rhythm other than the sinus rhythm, they are called arrhythmia. When the impulse, either they are not arising from the AC node or they are arising from the AC node but traversing via the different pathway. Any pathway is blocked, it is traversing via a different pathway. So that can result to arrhythmia. There are lots of arrhythmia. It can be supraventricular arrhythmia, it can be ventricular arrhythmia. ठीक है से? So any type of arrhythmia is possible with the use of digoxin toxicity. Almost every type of arrhythmia can be produced. Pulses bigeminous is common. Other than nodal and ventricular tachyarrhythmias or extrasystoles, ventricular tachycardia may occur and may terminally shift to ventricular fibrillation. Partial to complete atrioventricular block may occur, or it may accompany other arrhythmia, severe bradycardia, atrial extrasystoles, atrial fibrillation, or even atrial flutter may occur. Next. In about 2/3 of the patient having digitalis toxicity, the initial manifestations are extracardiac. In the rest 1/3, the manifestation can be cardiac initially. এটা কেন বললাম? যাদের এক্সট্রা কার্ডিয়াক ম্যানিফেস্টেশন থাকে তাদের ইন কেস অফ ডিগক্সিন টক্সিসিটি যদি ডিগক্সিন বন্ধ করে দিই তাতেই কাজটা হবে। No other drug is required. But in patient of arrhythmia due to digoxin toxicity, other drugs has to be used. Now, treatment of digoxin toxicity. First, the drug has to be stopped. So, further doses must be stopped at the earliest sign of toxicity, be it extracardiac or the cardiac. Nothing more needed to be done in most of the patient, especially if the symptoms are extracardiac. Now, if a patient present with tachyarrhythmias, now তার মধ্যে যদি chronic use of digitalis থাকে and the patient is on diuretic causes hypokalemia, and the chronic use of digoxin can cause hypokalemia. So what happens? Potassium infusion can be helpful. We have already read that potassium reverses the toxicity of digoxin because they are decreasing the binding of digoxin to the sodium potassium ATPase enzyme by conformational change of the enzyme. So potassium infusion given intravenously or orally in milder cases, but it should not be given in patient with acute toxicity of digoxin. Large doses of digoxin acutely has caused toxicity. সেখানে ইউজ করব না, and in patient in variable atrioventricular block সেখানে ইউজ করব না। কেন? In case of acute large dose toxicity of digoxin, hyperkalemia is occurring extracellularly. সোডিয়াম পটাশিয়াম ATPase পাম্প যদি বন্ধ হয় তাহলে কি হবে? সোডিয়ামটা ভিতরে যাচ্ছে না, পটাশিয়ামটা বাইরে যাচ্ছে। সোডিয়ামটা ভিতরে বেশি থাকছে, পটাশিয়াম বাইরে বেশি থাকছে। So in acute toxicity of digoxin, extracellular potassium is increased. So if we give more potassium, that will be detrimental. And again, in case of higher atrioventricular block, complete AV block may occur and even ventricular asystole may occur. It should not be given. It is desirable to measure potassium to guide KCL therapy in the digitalis toxicity patient. এটা প্রচুর ডিস্টার্ব হচ্ছে। Now, ventricular arrhythmias, they are the drug of choice lidocaine. Intravenous is the drug of choice. Quinidine, procainamide, propafenone are contraindicated because they will cause more atrioventricular block. Supraventricular arrhythmias, propranolol may be given intravenously or orally depending on the urgency. Atrioventricular block and bradycardia Atropine can be given. Cardiac pacing through a temporally inserted pacemaker can be used. Cardioversion by digital is contraindicated in digitalis toxicity patient because digoxin antibody. Digoxin antibody was basically prepared initially to measure the digoxin level in the blood by radioimmunoassay, but it has been found to be useful even in the digitalis toxicity patient. Now these are basically the FAB fragment of the antibody. FC, because of absence of the FC portion, it is non-immunogenic. It is marketed in Europe as DigiBind and DigiFab. Toxin as well as many other related glycosides given by intravenous infusion. Now precautions and contraindication. Hypokalemia. It increases digitalis toxicity. Elderly renal or severe hepatic disease can cause increase in digitalis toxicity. Thyrotoxicosis patient make the patient more prone to digitalis arrhythmia. Hypothyroid patient, the elimination of digitalis is slowed. As a result, digitalis accumulation occurs. Contraindicated in ventricular tachycardia as it may precipitate ventricular fibrillation. So in VT patient, lidocaine is used. Partial AV block may be converted to complete AV block. Contraindicated in WPW syndrome. WPW syndrome মানে ফুল ফর্মটা কি আছে? WPW syndrome ফিজিওলজি তো হয়েছে তোমাদের। উলফ পার্কিনসন হোয়াইট সিনড্রোম কি হয় তাতে? কে বলতে পারবে? বলো। উলফ পার্কিনসন হোয়াইট সিনড্রোমে একটা অ্যাবারেন্ট ট্র্যাক তৈরি হয়। নর্মালি কি হচ্ছে, এসএ নোড থেকে ইম্পালসটা এবি নোডে আসছে, এবি নোড থেকে ভেন্ট্রিকেলে যাচ্ছে, তাই তো, ভায়া বান্ডল অফ হিস অ্যান্ড প্রোটিনজে ফাইবার্স। নাও এবি নোডের জায়গায় আরেকটা বাইপাস ট্র্যাক তৈরি হচ্ছে যেটা অ্যাট্রিয়া থেকে ভেন্ট্রিকাল ইম্পালসটা কন্ডাক্ট করছে, তাকে বাইপাস ট্র্যাক বলা হয়। অ্যান্ড দ্যাট আকার্স ইন WPW syndrome and that is causing re-entrant tachyarrhythmia. Now they are contraindicated in WPW syndrome. Interaction, diuretics. Already discussed, hypokalemia increases the risk of digitalis toxicity or arrhythmia. Calcium synergizes with digitalis and precipitate toxicity. Already we know digitalis causes increase in the calcium concentration in the myocardial fiber. More calcium, more toxicity. Quinidine, they reduces binding of digoxin to the tissue protein. Basically they are inhibiting P-glycoprotein. It's the efflux transporter, and hence the digoxin binding to the protein is reduced, and also the renal and biliary clearance are reduced, causing digitalis accumulation and toxicity. Verapamil, diltiazem, captopril, propafenone, amiodarone, they are increasing plasma concentration of digoxin to variable extent. Adrenergic drugs can cause more digitalis arrhythmia. Absorption may be reduced by metoclopramide, sucralfate, antacids, sulfasalazine, neomycin, and may be increased by atropinic drugs including tricyclic antidepressants. Propranolol, verapamil, diltiazem, and disopyramide may additively depress the AV node conduction and oppose positive inotropic action. Usage of digoxin in two conditions it is used. One very important, heart failure, and the next one is cardiac arrhythmias. Heart failure, already said, digoxin is the only cardiac glycoside that is currently in medical use. Not digitoxin, not uaben, not others. Now, they are causing increase in force of myocardial contractility without disproportionate increase in the myocardial oxygen demand. Thus, they are increasing the myocardial efficiency. They are definitely relieving the symptom of heart failure, but they are not reversing the pathological effects, pathological changes in the heart that are occurring due to the heart failure. That is myocardial remodeling. They are not reversing it. So, they are beneficial in relieving the symptom of heart failure, but they are not reducing mortality. Okay. Now, coming to cardiac arrhythmias, number one, they are used in atrial flutter patient and atrial fibrillation patient, irrespective of the presence of heart failure or not. Now, they are used in, why they are used? They are not curing the arrhythmia. They are decreasing the ventricular rate. So, they are used in controlling ventricular rate, whether associated with congestive heart failure or not, but incapable of curing arrhythmia. আমরা অ্যাট্রিয়াল ফ্লাটার অ্যান্ড অ্যাট্রিয়াল ফিব্রিলেশন পেশেন্টকে দুভাবে চিকিৎসা করি। একটা রয়েছে হার্টবিটটা কন্ট্রোল করে, ভেন্ট্রিকুলার রেটটা কন্ট্রোল করে, একটা রয়েছে রিদমটাকে রিভার্ট করে। It is not reverting the arrhythmia, it is controlling the ventricular rate. Often the atrial fibrillation may be atrial flutter may be converted to atrial fibrillation. How? We all know that digitalis, they are decreasing the effective refractory period of the atria, and thus the basically many focus in the atrial flutter মানে কি হয়? Atrial flutter এ many focus of the atria are developed. এসে নোট থেকে ইম্পালস তৈরি না হয়, বিভিন্ন atrial ectopics থেকে ইম্পালস তৈরি হচ্ছে, but they are homogeneous, they are regular. মানে atrial beat are developed at a regular rate, at a rate of around 150 to 200, and they are passing via the AV node at a regular interval. মানে যদি 150 খানা atrial impulse টা তৈরি হচ্ছে, তার মধ্যে মেবি 2:1 ব্লক ইজ দেয়ার, প্রত্যেকটা একটা ইম্পালসের পর একটা ইম্পালসটা ব্লক হয়ে যাচ্ছে, but 1:2:1 or 3:1, these are the mode of blockage in atrial flutter patient. Atrial fibrillation এ কি হচ্ছে, atrial rate is very high, around 250 to 500, and they are inhomogeneous, they are beating irregularly, and many of the beats are blocked by the AV node because they are not strong enough to pass through the AV node. These are the difference between atrial flutter and atrial fibrillation. Now, what is happening? Because of increase in the effective because of decrease in the effective refractory period of the atria by the digoxin, the atrial rate becomes higher and becomes inhomogeneous, and hence the atrial flutter is converted to atrial fibrillation, and this is a welcome sign in treating a patient of atrial flutter, because ventricular rate can be controlled easily in VF patient, in atrial fibrillation patient than atrial flutter. So we are preferring if a patient gets converted from atrial flutter to atrial fibrillation. So often the atrial flutter patient may be converted to atrial fibrillation. They reduces ventricular rate. They reduces ventricular rate by decreasing the number of impulses that are able to pass down the AV node and bundle of keys, and thus they are decreasing the ventricular rate. They may be used for long-term ventricular rate control in persistent or permanent atrial flutter or fibrillation patient, but not preferred drug for rapid control of heart rate. because they act very slowly. Digoxin is not only slow but also less effective. So, drug of choice in a patient of atrial flutter or fibrillation are beta blockers, verapamil, diltiazem, because they are more effective, more rapidly they act, and lesser toxic. Decreases ventricular rate in dose dependent manner. Maintenance dose can be determined by titrating with heart rate. Can also be combined with beta blocker or calcium channel blocker if a single drug fails to control the heart rate. Now, second arrhythmia where digoxin may be used is the paroxysmal supraventricular tachycardia. Is a common arrhythmia with a rate of 150 to 200 and 1:1 AV block. Atrial flutter 1:2, 2:1 বা 3:1 ছিল, এখানে 1:1, যতটা অ্যাট্রিয়াল রেটটা আসবে ততটা এভি নোড দিয়ে কন্ডাক্ট হবে। So if the atrial rate is 150 to 200, the ventricular rate will be same in PSVT. Okay, digoxin injected intravenously increases the vagal tone and thus they depresses the path through the AV node or the ectopic focus. They terminate PSVT in 1/3 of the cases. Although digoxin may be used, but the adenosine is the drug of choice in PSVT. Also, verapamil, esmolol, they are more effective, less toxic, and act faster. Drug of choice in PSVT is adenosine. Okay.